Okay, look for this in the absence of clinically evident hemolytic anemia, positive direct Coombs test. These both has been added to the immunologic criteria of SLE. It's a new one. This can definitely be asked because SLE is a hot cake for MCQ setters. SLE, any number, more specific, more sensitive. Cardiac block, what comes? Shrinking lung syndrome, what comes? Neonatal lupus, what comes? Drug-induced lupus, what is the antibody? Lots and lots of questions. Which is perinuclear, which is speckled pattern, which is centromeric. To the new one, add two more things for immunological criteria: low complement and direct Coombs in the absence of clinically evident hemolytic anemia. Okay, fine. The next one. In graft rejection, there's not much of a change. Only one new thing has been added. Natural IgM antibodies are responsible for hyperacute rejection. Now the incidence of hyperacute rejection is very, very low. The incidence of hyperacute rejection is very, very low because for any graft we do a test called donor specific antibody test. This is done for all surgeries, all graft surgeries. So if this is positive, the graft surgery will never take place. So this will almost eliminate hyperacute rejection. The only new thing added is natural IgM antibodies are responsible for hyperacute rejection. IgM antibodies, and it's natural. Okay. Few things about HLA matching which can be future question is, how do you do a HLA typing? The types in which HLA typing are done are serological, tissue and molecular. In labs we use molecular. This is not done, it's only for research and it takes much of time. Molecular typing of that, the preferred is PCR SSP is sequence specific priming, and SSOP is sequence specific oligonucleotide probes. These two are the most commonly done method in laboratories. So write this down because this has not been asked. It's potential they can ask this. Serological methods are complement dependent cytotoxicity. This was the most commonly done. It was previous era's test. And micro lymphocytotoxicity. This question has been asked in microbiology. This was a repeat question in microbiology. Micro lymphocytotoxicity test. And in molecular testing, PCR based assay of sequence specific priming and sequence specific oligonucleotide probes. Okay. Three types of HLA matching: serological method, tissue typing and molecular. Tissue typing is not used for diagnosis. The most commonly preferred diagnostic thing is molecular. Of that, PCR SSP sequence specific priming and sequence specific oligonucleotide probes are the much more preferred. Since I have come to HLA typing, HLA score of 10/10 is needed for bone marrow transplant, and HLA matching is not done in liver transplant. These two are famous MCQs, just to recollect the points. Okay, this is not new, just to recollect the points. Genetics. Genetics has a great deal of change. This is what I do for work, so it's close to my heart, and I'll go to it. There are types of mutations, different types of mutation: a silent mutation, a conservative, non-conservative, frame shift. All these are types of mutation. What is a nonsense mutation? Good. Nonsense mutation is when as a result of a mutation, a stop codon comes. What is stop codon? That UAG, UGA, UAA. Okay, so this is a normal thing. Okay, a normal stretch. It's UAU. It's something like UAU A, C, some dot dot dot. So as a result of a mutation, this becomes UAG. This is read as a stop codon, right? So ideally, when this happens, my mRNA will sit here and keep on reading, right? And it will keep on producing the protein. So if there is a mutation here, it will come and say, okay, the protein is ended. So it should form this protein, right? It should form the premature protein, but it will not happen. It will not form any protein. Why is this? It's because of this concept of mRNA decay. If a nonsense mutation is introduced, what it does is it will destroy the mRNA. So when the mRNA is destroyed, there is no protein production. This concept of mRNA decay has been introduced in Robbins. When I report genetics, so whenever I find a nonsense mutation, we add this word, nonsense mediated mRNA decay. That's possible. It can result in no protein at all. Okay, that's a new terminology, nonsense mediated mRNA decay. Great. Next one. Yep. Marfan syndrome. Marfan syndrome, there are two types of Marfan syndrome. Marfan syndrome 1 and Marfan syndrome 2. This is an old concept. 8th, 9th edition of Robbins had this, but none of us will emphasize on this Marfan syndrome 2. But this should be emphasized. I'll tell why. Marfan syndrome 2 is a gain of function mutation in TGF-beta2 receptor. Write this down. Marfan syndrome type 2, it's a gain of function mutation in TGF-beta type 2 receptor. Why this is needed? Because it has led to a great breakthrough. Okay, how? So we all know Marfan syndrome mutation is a mutation in fibrillin 1 gene, right? So we have, I'll just put a picture of aorta. Roughly, aorta is an elastic artery. So all these are the elastin fibers. There's no mutation in elastin, there's a mutation in fibrillin. What fibrillin does is, it holds this elastin fibers like this. So it makes a thick bundle. It gives the strength. Also what it does is, wait, so when this fibrillin is mutated, what should have ideally happened is, the elastic fiber should be separated wide apart, right? If fibrillin mutation is there, this should have been the picture. But we know what is the picture. What is the picture in Marfan's? It is cystic medial degeneration, right? What happens in Marfan's is, the tunica media of the elastic artery has broken elastic fibers, cyst like spaces. Broken, it will be broken. Why it is breaking? If we consider this as a broomstick, if the thread is gone, each stick of a broomstick should be separated apart like this. But why this happens? This was a burning question. Why this happens? Then they found out fibrillin not only unites this, fibrillin also has TGF-beta, which it keeps it in inactive state. So when fibrillin is mutated, the TGF-beta is released. The TGF-beta is free. This TGF-beta causes the destruction of the elastic fibers. Isn't it great? Come on, the amusement is not stopped here. It'll go to the next level. Elastic fibers. Okay, so now what is the cause of the mutation? Is TGF beta is destroying. So now comes the second one, Marfan syndrome type 2, which I said is a gain of function mutation of TGF beta receptor. Right, so this TGF beta has a receptor. So this will be activated only when this TGF beta comes and sits. But in Marfan syndrome type 2 there is a gain of function, means in the absence of this will be activated and it will produce destruction. Okay, so fibrillin can be completely normal. Gain of function mutation of TGF beta to receptor will cause Marfan's. One more new point has been added in Robbin's this edition is TGF beta, not the receptor, TGF beta 3 per se mutation increases the predisposition for aortic aneurysm and cardiovascular manifestations. They have not classified this as Marfan's, but they have said that it increases the risk of aortic aneurysm and cardiovascular manifestations. That can be a question. Which of the following protein mutation can result in increase in risk of aortic aneurysm? That can be a question. The answer should be TGF beta 3. So what is the use again? As I said already, no implication, don't read. That's useless. What's the flying range of Aedes mosquito? We have to read this because it has an implication. Flying range is 100 meters. My country doesn't have yellow fever, so airports at least for 1 kilometer radius Aedes should be absent. So if any patient with yellow fever comes in also, it will not affect me. So anything reading any MCQ point will have an implication. Right, so what's the implication of this TGF beta and all those things? Okay, this is a screenshot from Robbin's 10th. Managing Marfan's is another just a brick in the wall. Now they have identified that losartan, which is a antihypertensive drug, so cheap and so easily available, which also blocks the TGF beta receptor. So isn't it great? You identify a patient of Marfan's, just give him losartan. Simple, as simple as that. He can have an awesome normal life. It's amusing, is it? Yeah. So losartan, if you give losartan daily, it has been evaluated. This could be future MCQ also. Losartan can provide a solution for Marfan syndrome. Just a tablet within $10. Just tablet can produce a solution to Marfan syndrome. This is amusing. This is science. Okay. Fine. Gaucher's. What is a Gaucher's disease? It's a lysosomal storage disease. Right. And it's the most common lysosomal storage disease. Have you ever seen a patient of Gaucher's? Pictures at least you must have seen. A big pot belly, big baby, thin, lean. My pictures are worse. A thin, lean baby with a big pot belly, saying it's hepatosplenomegaly. The baby will be very thin. And my doubt was that Marfan's is a storage disorder. So the macrophages come and get stored here and there. So why should it cause death? It's just getting accumulated. Why should it cause death? Now the concept of Gaucher's is a bit changed. They are now thinking that Gaucher's cell is not just sitting there. The Gaucher's cell is not just sitting. It is secreting interleukins and tumor necrosis factor continuously, creating an environment similar to, you must have heard of this term, cancer cachexia. That's why the kids are so lean, because TNF interleukins, they eat away the flesh, they increase the basal metabolic rate. That is one of the cause of death in Gauchers. So the entire concept of Gauchers has a change now. So it is like a cancer cachexia, right? Wait. Don't stop with Gauchers, continue with Gauchers. Gauchers are three changes in Robbin's 10th. Gauchers is also told to be linked with Parkinson. This is a MCQ, very good MCQ question. Gauchers patients have 20 times risk of Parkinson's, and 5 to 10 patients of Parkinson's have mutations in the enzyme glucocerebrosidase. Good. There is a reciprocal relation between the level of enzyme and alpha-synuclein, which is the pathogenesis of Gauchers, right? Sorry, which is the pathogenesis of Parkinson's, right? The alpha-synuclein. Again, what is the use, man? What's the damn use of this? If I don't have a use, I don't read. What's the use? See, this is the use. Reciprocal relation means enzyme, the glucocerebrosidase enzyme level is inversely proportional to alpha synuclein, right? So in Parkinson's, this increases, so this decreases. This is an equation. This is simple max. It's an equation, right? So is there a possibility if I increase this, this will decrease? It's an equation, right? It is possible. So what is the use? Come on, what is the use? The use here is, if I use the glucocerebrosidase enzyme, can I cure Parkinson's? That is the use, and that is the trial going on. Great, right? I'm just giving an enzyme glucocerebrosidase, and trying to decrease the level of alpha-synuclein, and thereby trying to prevent or treat Parkinson's. Parkinson's, as of now, don't have a definitive treatment. There are various classifications of drug. One gets resistant, levodopa, carbidopa, blah blah blah, ropinirole, and everything increases. At the end of the day, the patient is going to be resistant for everything. So if I can reduce the pathogenic product, I can have a cure to the disease. That's why this is useful. Come on. The next update in Gauchers is substrate reduction therapy. A, glucocerebrosidase. B. This is the equation. What's the treatment for Gauchers now? That's also an MCQ. Enzyme replacement therapy. Enzyme replacement therapy. Right. We replace glucocerebrosidase. So this is okay. X gives rise to A, which gives rise to B in the presence of this enzyme. So the substrate reduction therapy aims at reducing A, reducing the amount of production of this A. So this will be decreased, so the symptoms will be gone, or symptoms will be decreased, right? So what do I do is, I have an inhibitor of this enzyme, glycosylceramide synthase. Okay, this is glycosylceramide. I have an inhibitor of this enzyme. There must be a question arising, what is the use of it? I have already a good treatment option. Why should I unnecessarily poke my nose. Tell a common inhibitor, enzyme inhibitor. ACE? ACE inhibitors? Right? How most, at least, 50% of your parents will be diabetic and hypertensive. What's the cost of a enalapril? It's very cheap. So if I have an enzyme inhibitor, the treatment is going to be in 50 rupees. But to replace an enzyme, it needs very strict conditions because enzymes are degraded very fastly. So this is very costly. It's not possible for any family to have a lifelong enzyme replacement. So I have an enzyme inhibitor. It's as cheap as an ACE inhibitor. So it's a good alternative option. So substrate reduction therapy is tried in Gaucher's. Okay, again 3 updates. This is the wrinkle tissue paper appearance of the Gaucher cell. This could be an image based question also. There are 3 updates in Gaucher. One is the concept of Gaucher is changing. It's not just a storage disorder. The stored macrophages are producing interleukins, TNF. That's why the baby have a very lean appearance and all the things is being changed. The next one is Parkinson's and Gaucher's are linked. The use of this is there's a reciprocal relation between the level of enzyme and the alpha-synuclein, which is a pathogenic product in Parkinson's. So ulta, increase the level of glucocerebrosidase, you can find a cure or you can treat Parkinson's better. The trial is going on. Substrate reduction therapy, it's an alternate cheap option for enzyme replacement therapy, right? These 3 are the beautiful thing in Robbin's 10 regarding Gaucher's alone. Okay. Non-invasive prenatal testing. It's called, sorry, that's not NPT, that is NIPT. How many of you read newspapers? Recently there was a court case in Mumbai that a mother wanted to abort her Down's baby, right? Abort her Down's baby, which is greater than 20 weeks. The legal limit of abortion has been crossed. So the court gave a verdict that the mother cannot abort. Mother cannot abort. She has to give birth to the Down's baby and live with the Down's baby forever. That was the court's verdict because it is by law. Why this thing happens is, what is the time in which anomaly scan is done? Like 14 to 16 weeks. So in anomaly scan, you suspect Downs, then you do a chorionic villus sampling, and that also has a particular week to be done, and then you can say chorionic villus obviously has many complications, and then you can say the baby is having Down syndrome. The baby is having Down syndrome. Then you can say the baby is having Down syndrome. So this takes time. So unfortunate cases, it takes more than 20 weeks. That's a legal limit of abortion in India. So to prevent all these consequences came non-invasive prenatal testing. Now if you know what is this, you will really, it is really awesome. We'll say, I'll come to this liquid biopsy again later. What is non-invasive prenatal testing is, first point, it is done at 10th week of gestation, and the results will be available within 3 to 4 days. Second, as the term indicates, it's non-invasive. Non-invasive here, what do I do is, I'll take the pregnant mother's blood. See the beauty of science. I'll take the pregnant mother's blood. In that mother's blood, there is something called free fetal DNA. The baby's DNA will be present in the mother. So I isolate this DNA and look for trisomy. Pretty amazing, right? That's non-invasive because I'm not touching the baby. I'm not poking, I'm not doing a severe sampling. I'm just taking a mother's blood, like a simple blood sugar test. I just take the mother's blood, isolate the free fetal DNA from the mother's blood, and then I do a trisomy 21 analysis, and then I give a report. The baby is fine. Come on, go ahead with the pregnancy. The baby is not fine. Not fine, I'll give the report at 10th to 11th week. Go and abort. Easily. There's no complication. There's almost 98 to 99% sensitivity and specificity. It's perfectly beautiful. And this is done in India, and we do this. So what is liquid biopsy? This process is called liquid biopsy. And I am saying this, liquid biopsy is an umbrella term. Liquid biopsy is like a bigger term, of which one of them is NIPT. You know, the other beauty of liquid biopsy is, it's mind-blowing. The other beautiful thing of liquid biopsy is, I take the blood of the patient, and from the same method, like instead of free fetal DNA, I see free or circulating tumor DNA. I take the circulating tumor DNA. What's the purpose? Extrapolate. Come on, think. Where can I use this? In any brain tumors, now I don't need to drill a skull and take a biopsy. I am not looking at drilling the skull to take a biopsy. I'll just take the patient's blood, and I can tell whether the patient is suffering from GBM or not. Superb, right? This is the other use of liquid biopsy. And why did I say especially GBM is, this has been patented by a company in India. This method has been patented by a company in India. So this is a great thing, and has been followed in Apollo, Mumbai. Right. So stories apart, NIPT, this is there in Robbins. This word also has been introduced in Robbins 10th edition. NIPT is a very good alternative method for Down syndrome detection at a very early age with a very good sensitivity and specificity, and it is non-invasive because I am just taking the blood of the mother and I am not touching the fetus. It comes under a umbrella term called liquid biopsy, which can be used to diagnose inaccessible tumors like brain. I don't need to take a brain biopsy for diagnosis. I can just take the blood, see the circulating tumor DNA, and say whether the patient is having GBM or medulloblastoma or not. Okay, this is a new concept altogether. This is even more amazing. This was actually discovered in 2016, I think, 15 or 16. And this has also been introduced in Robbins 10th. The author of Robbins, Dr. Vinay Kumar, is on Facebook. You can send a request to him. When I read this first, I just texted him that so CRISPR is in Robbins and it's awesome. And what he said is, yeah, CRISPR will be in other pathology books after 5 years. Robbins is the first one to introduce it. Yeah, obviously Robbins is the first one to introduce it. What is CRISPR? Expansion of CRISPR can be an MCQ. Clustered, regularly interspaced, short palindromic repeats, that is called CRISPR. And Cas is caspase. CRISPR associated gene or caspase CRISPR associated gene is almost always called as Cas CRISPR. CRISPR is nothing but, you remember like this for your ease, CRISPR is nothing but molecular scissors. CRISPR is a molecular scissor. What CRISPR does it cuts a DNA. Okay, it cuts a DNA and introduces what I want. Introduces another DNA, another synthetic DNA. Right? It's a molecular scissor. There's a DNA like this. What my CRISPR does is it cuts this part. Okay, so something like this becomes. And what it does it cuts that part, and instead of that it adds a new desired thing which I want. This is CRISPR. It adds a new thing which I want. So tell me how it is useful. Any point mutation, you can use CRISPR and correct it. A point mutation, right? You can use CRISPR and correct it. Example, sickle cell anemia. Beta 6 chain position, 6 position, glutamine to valine. So I can use CRISPR. If this is beta globin gene, I can cut that 6th position and introduce a normal 6th position. Then it will be a perfectly normal red blood cell and not a sickle cell. Right? Right? Great, no? Yeah, it is great. So CRISPR is a new method of gene therapy. First MCQ. The expansion of CRISPR can be asked. It's always called as Cas CRISPR. And one more important thing is NAGH and HDR. Just remember the names. This can be asked. Non-homologous end joining, that is NHEJ. It's used for mutations. For example, like sickle cell anemia or any deletion or insertion. Homologous recombination is used to introduce a new sequence. Where this is used, for example, you have deletion of 22q. Okay, you have deletion of what disease it is? It is great. It is DiGeorge. So using this method, I can introduce this into a gene, into a cell. So for a mutation like sickle cell anemia, I use a method of non-homologous end joining. And for insertion or introducibility, and when mRNA comes here, it will not be able to pass this. That's how post-transcriptionally it silences protein. So the microRNA involved in neoplasms are called oncomRNAs. This was there previously. This oncogenic microRNA is introduced. Right? This is a post-transcriptional silencing. Fine. So for metastasis, it's easy. A gene is there, a metastatic inhibitor gene. For example, KISS. Okay, that's a metastatic inhibitor gene. So mRNA comes and destroys this. It will promote metastasis. That's a metastatic inhibitor. miRNA 200. And a tumor suppressor gene. Okay, there's a tumor suppressor gene. The mRNA is producing the tumor suppressor gene product. A microRNA 15 or 16 comes and sits here, blocks this product, so there is no tumor suppression, so neoplasia comes. Accepted. Straightforward. These two were there in 9th edition of Robbins. There's something new called oncogenic miRNAs. What is this? What it says is a proto-oncogene is converted to an oncogene, and this oncogene actually produces cancer. The mRNA which stops this oncogene should ideally prevent cancer, right? Right? That's the logic. Oncogene produces cancer. Oncogene produces cancer. So, a mRNA, if it post-transcriptionally stops the oncogene, it will prevent cancer. But it is said that because it stops, the end product is not formed. So, the production increases. Don't ask why the same is not followed here. It should be followed here also, but I don't know for what reason. Only in oncogene the production is increased, so it produces a more virulent tumor. That's the concept. For you to remember, oncoRNAs are of three types: metastatic mRNAs, tumor suppressor mRNAs, also a new one called oncogenic mRNA. The first one to be discovered is miRNA 17. This is new. MicroRNA that controls the expression of RAS, that's a proto-oncogene, and MYC is involved in lung cancer. Note this down. MicroRNA that control BCL, that's an anti-apoptotic gene, is involved in leukemia. Note this down. This can be asked. The first discovered microRNA is 17. MicroRNA that controls the expression of RAS oncogene and MYC is involved in lung cancer, and BCL2 is involved in leukemia. Two additional points about miRNA or microRNA. OncoMicroRNA has a new entity called oncogenic mRNAs, and miRNA associated with lung cancer and miRNA associated with leukemia. These two are two in Robbin's 10th edition. RAS. Okay, this still is the same. RAS is the most common oncogene or proto-oncogene mutated. It was 20% overall. Robbin's 10th has increased it into 30%. If they want to play with numbers, there's a good chance they can play with numbers. Same thing for P53. P53 is the most common gene mutated. It was around 50 to 55% previously. Now they have included greater than 75% of tumors have P53 mutation. Both the numbers have been changed. Now RAS incidence is 30%. P53 it is greater than 75%. These two numbers have been changed. So look for that. If there's a number question, look for these two options. Quiescence. This was previously also mentioned in Robbins, but the other name for quiescence is called a temporary cell cycle arrest. Now, this is a screenshot from Robbins 10th. It's called a temporary cell cycle arrest. Please note this down. This can be an MCQ. Just what is quiescence? Like senescence is a permanent cell cycle arrest. Quiescence is a temporary cell cycle arrest. And P53 is involved in quiescence. That could also be an MCQ. Temporary cell cycle arrest is called quiescence. Okay, it's a new terminology. I'll be telling further new terminologies down the road. Quiescence is called a temporary cell cycle arrest. Oncometabolism. Last time there was in 9th edition there was an introduction of something called chromothripsis, right? And this chromothripsis was asked in JIBMA exam. Now there is an introduction of something known as oncometabolism or oncometabolite. This can also be asked in any of the AIMS, JIBMA or PGI. What is an oncometabolite is, there are many enzymes in Krebs cycle, citric acid cycle, the normal Krebs cycle. Mutation of them will cause cancer. God damn, they are not leaving any gene at all. In future, I think any gene in body will cause cancers. Okay, those thing is the isolated dehydrogenase is a Krebs cycle enzyme, right? So mutation will produce a mutated isolated dehydrogenase. Okay, a mutated isolated dehydrogenase. So normal isolated dehydrogenase will have a different function, but a mutated thing will convert an alpha ketoglutarate to something called 2-hydroxyglutarate. This is an oncometabolite. This is an oncometabolite, and this causes the cancer. And this causes cancer. How? It has an epigenetic control. Epigenetic is by methylation it silences the gene, or histone modification it activates this gene. This oncometabolite has an epigenetic control and results in tumor formation. What you have to know is oncometabolism or oncometabolite are mutation in enzymes in Krebs cycle. First MCQ. Krebs cycle enzymes. Two of the enzymes have been extensively involved. One is IDH, that's isolated dehydrogenase. Another one is SDH, that is succinate dehydrogenase. Succinate dehydrogenase. These both are the enzymes which are involved. And the oncometabolite of IDH is 2-hydroxyglutarate. That's the oncometabolite. Okay, 2-hydroxyglutarate here, see. 2-hydroxyglutarate is the oncometabolite. That can also be an MCQ. And the fourth MCQ is, which tumors do you see them? IDH mutation is seen in, write this down, this is very potential MCQ for PGI. IDH mutation is seen in cholangiocarcinomas, gliomas, acute myeloid and sarcomas. I rounded gliomas and ticked the others because IDH mutation is done in gliomas for the past 3 to 4 years. We are doing IDH mutation whenever we report a glioma because the prognosis varies. So gliomas can be asked in NEET because it is very well known for among pathologists. IDH mutation is in cholangiocarcinomas, gliomas, 10 to 15% of acute myeloid leukemias and sarcomas. SDH mutation is seen in GIST and renal cell carcinomas. I'll ask this again down the lane. Let's see how many of you remember it. IDH is seen in cholangiocarcinomas, gliomas, acute myeloid leukemias and sarcomas, and SDH is seen in GIST and renal cell carcinomas. Okay? Written? Yeah. We'll go to the next one. Yep. Immunotherapy and cancer.